Well, good afternoon, everyone. I have the honor to introduce Alex. Alex has been presenting functional medicine concepts for really the past 15 years. He's a graduate of Western States Chiropractic College. Then he went on to my alma mater, which is Bastyr University, a naturopathic school, graduated from there, and now he is getting his trifecta, and he's going to osteopathic school. He's currently in osteopathic school. He has done a tremendous amount of literature review, particularly on arthritis, autoimmune conditions. He's written a number of wonderful books, and in particular, I'd like to direct you to one of our new monographs that Alex has authored on pain, and that's a monograph that you can review at the IFM bookstore or the IFM section of the exhibit hall. With that, I'd like to turn it over to Alex, and Alex is going to run through his presentation, and then at the end of his presentation, he will answer questions. So we'll want to hold questions until the end. So with that, I'll give it to Alex.
How's that? That's pretty good. My name is Alex Vasquez, as Dan just reminded you. And we're going to go through autoimmune disorders at a pretty quick pace. I've got 150 slides that we're going to try to get through in about 70 minutes, so that's going to be pretty quick. It's not a world record, at least not for me. My record's 330 slides in 90 minutes, but it's still going to be a pretty fast pace. And the format of these slides is slightly different than what I'm used to, so I don't have my color coding and my cues like I'm used to, but we'll simply do the best that we can, starting almost right now. Got to get the right watch up. There we go. Okay, so 70 minutes, autoimmune disorder. So in order to make this clinically relevant, and obviously, as Dan just said, our goal here is to actually implement some clinical behavioral change. So just try to picture a patient in front of you who's got some autoimmune disease. Let's assume it's the prototype autoimmune disease, rheumatoid arthritis. And let's assume that the pharmacy's closed, perhaps, and you have to do something to get this patient better without the use of any anti-inflammatory drugs. Their life and death is right there in your hands, and the prescription pad is broken for the day. So with that in mind, we're going to get through these objectives in a few slides. I've got some slides in here that I consider to be background information. We're not going to go through those in a lot of detail. I just wanted you to have them for your notes. So some of these slides are in here only so that they would get printed in your notes, and we're going to basically skip over them. We might highlight a few important points here and there, but especially in the front end of this presentation, we're going to have to skip over some of the basic info. And some of it's basic information you could get out of any pathology or clinical medicine book. And that's obviously not what you're here for. You're here to get kind of the integrated approach, which is in the latter half of the presentation. So we're going to fast forward through the first half, or first about 40 slides, and then get to the back end of it. The ultimate goal, of course, being to apply some of these practical applications using a functional medicine matrix model. As Dan said, I just reviewed this literature, I guess, for the third time, writing the IFM monograph, which is out there at the IFM booth. And that monograph talks about rheumatoid arthritis, which is what we're going to talk about here. It also talks about migraine headaches, low back pain, and fibromyalgia. Okay, so a lot of this, like this slide, for example, is mostly background information. You have it in your notes. We're not going to spend time going over it right now. What we are going to emphasize throughout the presentation is antecedents, triggers, and mediators. And the take-home message, of course, as Dan said, is to emphasize, let's see, what do I have here? I don't seem to have a laser pointer. But we're going to try to emphasize a practical approach that you can use in your office next week. And the way to be sure that you can use it next week may or may not be to try to focus on details. It's just to try to focus on concepts. And so the way I look at inflammatory diseases is just to look at what are the triggers that would cause an inflammatory balance. And it's not that the autoimmune disease is creating itself necessarily, even though there are some vicious cycles that eventually become important factors. But what would create immune dysfunction? And let's say a patient's otherwise healthy. What would create immune dysfunction in a patient who's otherwise healthy? If you can make a long list and go through that list when you're working with a patient who has autoimmune diseases, then you have a few ways that you can intervene without trying to address their disease per se. You're just trying to address the underlying causes of the immune dysfunction or immune imbalance. So we're going to talk about, let's see, what is it? Clinical competence and safety. That's background information. You've got it in your handouts. I might talk about it real quickly, but we're going to go through it at a pretty quick pace. We're going to focus on diets, dysbiosis, and hormones for this presentation. Toward the end, there will be a little bit of discussion about xenobiotic immunotoxicity and some obvious psycho-emotional considerations. But the big focus, and I think where the big payoff is for most patients, is in diet and nutrition, dysbiosis, and assessing and correcting their hormonal imbalances. For some patients, obviously psycho-emotional stress is important too, but xenobiotic immunotoxicity is one of those things that can be kind of in the background, and at least for me, sometimes I don't really address it directly until the patient hasn't had a successful response to the other things that usually do elicit a successful response. I've got a case report that describes that pretty well in the IFM pain monograph. So these next few slides I just call rules of engagement. They're just to remind you that autoimmune diseases are pretty serious. As they were described to me at one point, autoimmune diseases are big league diseases. It's not just that the patient has a little bit of rheumatoid arthritis or a little bit of lupus. People can go from having a little bit of rheumatoid arthritis or a little bit of lupus to paralyzed within 24 hours if they develop transverse myelitis. So the reason I say that, first of all, is because a lot of my material in my books go to students, and I try to emphasize for them that they've got to play this safe. We have a lot of effective alternative and complementary so-called therapies, but that doesn't mean that we disregard the potential for these diseases to become emergencies. Transverse myelitis, for example, is something that can occur in patients with just about any autoimmune disease. And patients can go from barely symptomatic to paralyzed within 24 hours. Well, if that happens on your watch, you're the last patient, you're the last doctor who the patient has seen, you need to have a safety net built into your treatment plan so the patient knows what to do if it's Saturday afternoon and they start to get a little bit of numbness and tingling in their hands or feet or something. That could be the initial onset of transverse myelitis, and they need to know how to handle that in your absence. Thank you much. Much better. Yeah. I have a laser projector that works. So now you can see how shaky my hands are as I point to the screen. So, like I said, we're not going to go over these. I just wanted to make the point that I just made. Practice good medicine and practice defensively so that you're safe and so that your patient is safe too. Always have an internist or rheumatologist on board in case your patient has to be acutely immune suppressed. If they develop, for example, if you've got a patient with polymyalgia rheumatica and they start to develop vision changes, they can go blind within a day. And you don't want that happening to the patient, period, but you certainly don't want it to be somehow seen as your responsibility. So just be sure that you have to know basic disease and basic medicine and basic pathology in order to manage these conditions correctly. And you have to know what the potential complications are so that you can anticipate what they might be and implement that anticipation into your treatment plan. And I give you some suggestions for that. Sorry, I'm going to go back just one. Yeah, when in doubt, refer out for patient co-management. Don't learn that the hard way. And here's just some language that you can put into your treatment plans and also your consent form. I have I wouldn't say elaborate, but at least a sufficient informed consent form that people sign. And I also give people typewritten treatment plans at every visit, which includes some language such as, if you develop an emergency over the weekend and I'm not available, go to the hospital. Don't just wait for me and think I'm going to show up at the office at 2 a.m. on Saturday. So just practice defensively. That's what it says here, and that's why we're skipping over these slides. Musculoskeletal emergencies are important to consider, and hopefully these are things that you're familiar with. I just included the list to kind of refresh your memory, but as I said before, giant cell arteritis, for example, patients with that can become blind very quickly. I saw a patient about a year and a half ago. She was seen in a rheumatology clinic. She had temporal arteritis. She refused to take immune-suppressing steroids at the time, and the second visit she was blind in one eye. And it's just because she missed the opportunity to accept the, in her case, appropriate treatment for her condition, and it cost her her vision. Transverse myelitis, as I mentioned before. Acute compartment syndrome, that's more of a almost like more of an orthopedic or post-traumatic condition, but just be aware that there are musculoskeletal emergencies, and you need to know how to identify those and predict them and plan appropriately. So, paradigms. I think paradigms are an important conversation, and anybody who's been following Jeff Bland, like some of us have for the last 15 years, Jeff Bland at least is certainly talks about many different topics. One of his topics has been traditionally paradigms. So in that regard, we could say, well, paradigms have to do with how people see things, in particular how they see things that they don't recognize that that's their particular way of seeing things. So how do you see autoimmune and inflammatory disorders? What's their genesis and what fuels them? Those are the questions I asked there to kind of get that conversation started. There seem to be two major patterns of thought. One is that autoimmune diseases are idiopathic or mostly idiopathic, but of course there's a genetic component. The treatment approach that's used for that is perpetual and additive pharmacologic immunosuppression, crisis management, surgical management of complications, symptom suppression with anti-inflammation as the goal, and that seems to be kind of as far as it goes. There's another paradigm, the one that I've written about, and that is to view autoimmune conditions as multifactorial. So, in case I pass out on the stage in 20 minutes, there's one thing I'd like for you to do, and that is replace the word idiopathic with the word multifactorial. So anytime you're reading a book and it says multiple sclerosis is an idiopathic disease of unknown origin, scratch it out and write multifactorial, and then try to determine by your own literature review or by someone else's literature review what are the factors that would contribute to that disease. It's a whole new ballgame at that point. It becomes an active process. Rather than just saying, okay, well, there's nothing we can do, and the best we can do is suppress the immune system here. Well, maybe that's not the best we can do. We could say, maybe it's not idiopathic, maybe it's multifactorial, and then try to identify those different components and address them appropriately. What would some of those factors be? Dietary and nutritional interventions, hormone interventions, microbial and dysbiotic interventions. We'll talk about those in detail. Those first three items in the green, that's what we're going to focus on today. Probably not too much in the way of detoxification, although that's mentioned in my book in more detail, and some psycho-emotional interventions. Crisis management still has a role, even in this multifactorial holistic model, because not all patients are going to respond brilliantly to your plan, even if it's a great plan and even if they implement it successfully. So there's still a role for crisis management. That's why I'd like for you to have a rheumatologist or an internist on board when you're managing these patients, or somebody who can suppress them in your absence if that's what's necessary. But in this case, cure is the goal. And you'll see I've got a few cases in my own writings that I describe. And cure is the goal that I aim for. Cure doesn't seem to be the goal that's represented in a lot of the medical articles that I look at. For example, some articles talking about laboratory evaluation of lupus consistently say that once anti-nuclear antibodies are positive, they'll never become negative. Maybe you've seen that. I've certainly seen that many times represented in basic laboratory books and medical books. Well, that's not my experience. My experience is when I'm working with somebody who's got lupus, if they've got positive anti-nuclear antibodies, it's not unusual for those to become normal with treatment. So there's something different about the multifactorial paradigm and approach that seems to make it, at least at times, somewhat more successful or predictable than assuming things are just idiopathic. This is the IFM matrix that we've all worked on for the last couple of years. What we're going to focus on today is this inflammatory processes, because in this conversation, even though the symposium is on the topic of pain, we're presuming that pain has an inflammatory component. Specifically, we're going to assume that there's a component over here with immune imbalance, and we're going to focus over here on digestion absorption, because we're going to look at gastrointestinal dysbiosis as kind of a model for dysbiosis in general. Everybody here is familiar with dysbiosis, I hope. You will be by the end of the symposium. Well, you already are by now. But dysbiosis has kind of evolved. Our understanding of dysbiosis has evolved over the last couple of years. When I was in chiropractic college 12 years ago, there was a little bit of conversation, but mostly we talked about dysbiosis. And anytime somebody just says dysbiosis, they're usually talking about GI dysbiosis. But there are different locations for dysbiosis to occur. It can occur in the mouth, throat, lungs, nasopharynx, genitourinary tract, sometimes on people's skin. People can have skin infections that lead to arthritic syndromes. So you have to look beyond, and also just in the environment in general. So you have to look, when you're thinking dysbiosis and you're thinking trigger, you have to look beyond the gut. You have to look especially into like nasopharyngeal cultures and colonization, and also genitourinary cultures. So this is one of the diagrams I use in my book, which again kind of models. The patient comes to us with immune dysfunction, they're already right here. If all we do is assume that, if we just assume that this is happening kind of out of the blue, then all we do is focus on mediators and transcription factors and what we can do to interfere with that so that they don't ultimately have these adverse clinical manifestations. However, we can also look, we can do that. We can also, at the same time, look at their immune dysfunction and say, okay, well, what things would trigger immune dysfunction? Maybe it's their pro-inflammatory lifestyle and diet. Maybe they've got some multifocal polydysbiosis, which is my term for dysbiosis in several locations. That's why it's called multifocal. And polydysbiosis because people can have more than one dysbiotic microbe. They could have Candida albicans and Citrobacter frundii. They could have ureaplasma ureolyticum and group B strep. So you've got to look, especially in the more difficult cases, for more bugs and more locations. So we just looked at this. What I want to say here is, as long as you manage your patients effectively and responsibly, the decision's yours as to how you look at it, and you can certainly combine approaches. These don't have to be, as far as in terms of therapeutics, they don't have to be mutually exclusive. Now, the paradigms are somewhat non-overlappable, but the therapeutics, if patients got an autoimmune disease and you're treating them from a multifactorial standpoint, you still might have to do immune suppression or surgical management of complications, as I said before. A lot of this information will apply to different conditions. We're going to focus on rheumatoid arthritis as a prototype, but this would be particularly relevant for psoriasis, psoriatic arthritis, and of course the spondyloarthropathies. These next few slides just talk about rheumatoid arthritis, and it's just basic, well-accepted information, so I'm not going to spend a lot of time on it, other than to thumb through some of that basic, well-accepted information to see where we might actually have a way to intervene with integrative treatments. Immune complex deposition is very important in part of the pathology of rheumatoid arthritis, not only inside the joint, but also for some of the vasculitic complications. We all know what rheumatoid arthritis looks like. It's the prototype inflammatory arthropathy. You've got a list there in your notes of the classic presentations. People usually present with some degree of low-grade fever, or at least often. Be sure not to overlook infection, because patients with rheumatoid arthritis are actually have a higher prevalence of developing septic arthritis. So if a patient with rheumatoid arthritis comes into your office with a particularly hot joint, you want to make sure that you rule out septic arthritis. Upper spine involvement can cause atlantoaxial instability. Osteoporosis, of course, is common due to inflammation, disuse, and hormonal imbalances and drug effects. The arteries and vessels are affected. So here's my point in this slide, that rheumatoid arthritis, just like all of the autoimmune diseases, it's not just an arthritic complication. It's not just that they have pain, of course. They have complications in their skin, their arteries and vessels, pulmonary manifestations, eye complications, and they can go on to develop other autoimmune diseases, which would, by definition, suggest that there is an underlying immune dysfunction among these conditions, that they're not separate, that the pathologic feature is immune dysfunction, and what we tend to label it can actually vary not only from decade to decade within the science of medicine in some cases, but actually within the patient. Patient can go on to develop other autoimmune syndromes, in this case particularly Sjogren's, among rheumatoid arthritis patients. Women tend to be more susceptible to autoimmune diseases, and here are some reasons for that. It's usually been thought of as being related to estrogen, and there's certainly a good reason for that. However, women also suffer from more urinary tract infections for anatomic reasons. So what we're going to talk about, especially as we get into the later stages of this presentation, talk about rheumatoid arthritis, there's a very strong correlation in the research literature between urinary tract infections and the perpetuation and actual genesis of rheumatoid arthritis. So be sure to keep that in mind. Nutritional depletion due to pregnancy and lactation. When women are pregnant and lactating, through the process of bioconcentration, they tend to give off some nutrients to their fetus or infant, respectively, that actually have immune modulating effects. magnesium, EPA, DHA, vitamin D, things like that, which would all tend to make someone more susceptible to an autoimmune or inflammatory condition. We're going to emphasize dysbiosis pretty thoroughly. And as I say here, rheumatoid arthritis is associated with gastrointestinal and genitourinary tract colonization with Proteus mirabilis. And separate from that is the fact that 40% of patients with rheumatoid arthritis have small intestinal bacterial overgrowth. That's very important, and I'll emphasize that as we go through, but we're going to keep on making progress. Laboratory tests. The reason that you use labs, of course, in this case, would be to exclude other complications like septic arthritis or renal failure. Quantitatively assess patients' overall health status, including cardiovascular risk. Like the leading cause of death in patients with autoimmune conditions is renal failure and cardiovascular disease. So a patient comes into your office with arthritis, you still have to think of other aspects of their health. Determine the identity and nature of underlying contributors. So, for example, you can use lab tests to assess for nutritional deficiencies. You can look at their inflammatory state, which is very important because that gives you something objective to monitor for seeing how well your treatment plan is working. And after you have enough experience, you get to see how compliant your patients are. If you're doing a treatment plan that you know has worked in 100 patients and one patient is totally falling off the wagon and you have some other indicator, like they're not losing weight when they're 40 pounds overweight, then you know they're not following through with their diet. But you can use labs to monitor effectiveness and as an aspect of effectiveness compliance as well. As Dan alluded before, CCP antibodies are becoming the test for rheumatoid arthritis. If you have an asymptomatic patient with CCP, it doesn't mean that they have rheumatoid arthritis, but it means that they certainly are at higher risk. And in some of these studies, they've shown that CCP is actually a predictor of rheumatoid arthritis onset. So it might mean that a patient's heading toward rheumatoid arthritis, and the time to intervene is before they become symptomatic. CCP antibodies are considered to be the most valuable test out there right now, which is good because for a long time, of course, we didn't have a very good test. We just used rheumatoid factor, which was never very good. These are some other basic labs. CRP is probably the inflammatory test of choice these days. Ferritin is good. Some patients will present with what appears to be an inflammatory arthropathy, and it actually turns out to be hemochromatosis or iron overload. So check ferritin. It's important. Rheumatoid factor, we just talked about that. We'll skip over that. You've got it in your notes. A lot of patients with autoimmune conditions either have or develop thyroid disorders. And, of course, last year at our symposium in Arizona, we had talked all about thyroid disorders. So you can look at those notes, or you can look at the quick summary I've got right here. What might be new for some of you is the concept of assessing hormones in your patients with rheumatoid arthritis or any of the inflammatory disorders. So kind of a sequence of events, and you might want to write this down because this is about to be practical implementation. A typical sequence of events, obviously there are all these things we can do. So a patient comes in, where do you start? Day one, I always start with diet and some rather basic supplements. So we're going to talk later about something I call a Paleo-Mediterranean diet. I've written on it. You can Google me and Google Paleo-Mediterranean diet, and I'm sure you'll come up with something. So I always start with dietary intervention, which includes Paleo-Mediterranean diet. That cleans out the junk and gets them started on the right foods. In addition to that, you also have to consider food allergies, because just because a food is perfectly healthy doesn't mean your patient's going to tolerate it. And I've seen patients who are allergic to chicken broth. And I think probably chicken broth would be high on certainly my list in terms of one of the healthiest foods out there. Basic supplementation, multivitamin, vitamin D, combination fatty acids, and a probiotic. For me, that's day one, almost no matter what they come in with, and I've got the research to back it up. So just consider that, but like I said, we're trying to imagine here, what are you going to do beyond that? Well, certainly if you're working with a patient with autoimmune condition, start thinking about dysbiosis. And sometimes people don't want to go there, or they want to work on diet first. That's fine, but it's their choice. So when we start talking about hormones, I would consider hormones to be like a step 3. After we've done diet and lifestyle and supplements, after we've done basic dysbiosis testing, then I start to look at hormones. And sometimes we look at hormones on the first day. It just depends on the patient, and also depends, obviously, on my interpretation of their presentation. Patients with rheumatoid arthritis and other autoimmune conditions, I'm reading off the slide right now, commonly show elevations of prolactin and estradiol, along with insufficiencies of testosterone, cortisol, and DHEA. So that's the classic pattern that you'll see represented in the research. Now, there are some exceptions to the rule. Patients with Sjogren's syndrome tend to have higher levels of androgens, so the testosterone and DHEA information doesn't apply to them as well. But still, keep these things in mind and you'll see how they'll play out. So, let's see, a few more lab tests. You can do leaky gut tests with lactulose mannitol. Hopefully most of you are familiar with that. That's kind of the test for gastrointestinal function. In the case report that's described in the pain monograph, I discussed the use of lactulose mannitol assay. And for example, in this patient's case, he didn't want to do a stool test for whatever reason. And I said, okay, well, if you don't want to collect a stool sample, I can understand that. But how about at least doing a leaky gut test? And he said, okay. Well, he came back with the leakiest gut I'd ever seen. And I said, well, now will you consider doing a stool test? And then he said yes. So sometimes, there are different reasons to use tests. Obviously, I appreciate having the information, but sometimes you have to use one test